we're now going to shift gears a bit and talk about patient-reported outcomes. Doing that for us is Dr. Jeff Swigris from National Jewish. He's a professor of medicine there and part of the interstitial lung disease group, and has been really prolific in the development and implementation of patient-reported outcomes. So thanks, Jeff.
Thank you very much. I wear two hats. I'm a clinician who takes care of patients with pulmonary fibrosis, and I'm an investigator. I've spent the majority of my career trying to figure out how pulmonary fibrosis affects patients and trying to figure out scientifically rigorous ways to measure that. I changed the title of my talk from patient-related outcomes to patient-centered outcomes, just to remind us that patients are the central focus here, right? Why is it so important? Why are patient-centered outcomes so important? If you remember one slide from my talk, let it be this one. Whether you're an investigator, whether you're a basic scientist, whether you're a clinician, we all have the same goal, right? To either immediately or ultimately make the lives of patients better. As a clinician, I want to know how best to take care of my patients and their caregivers, because we know they're an integral component of the team. To do that, we need to figure out what matters to them and know the tools available to us to improve the quality of those things that matter. For the remainder of my talk, these are my objectives. I'd like to define patient-centered outcomes for you. I'm going to talk about which ones we all believe, and I think we will all agree on which ones are important to patients with pulmonary fibrosis. I'm going to share just a little bit of trial data on patient-centered outcomes, some of the challenges we face, and then I'm going to put my clinician's hat on and talk a little bit about how we maintain patient-centeredness in the clinic, and then some ideas for moving forward. So what do we mean by patient-centered outcomes? These are things, those of us who do research call them constructs, but they're things, they're symptoms, they're satisfaction, they're quality of life, some of them very abstract, but things that at their core are focused solely and entirely on the patient, and those things that matter most to patients. And typically these are questionnaires or surveys, and they can be very general. We might ask, how do you enjoy living in the town you live in? Or they might be very specific, like, how bad does your knee pain affect your ability to get outside the home? And in the case of pulmonary fibrosis, it might be, how short of breath are you, or how limited are you, or how's your cough, or your energy, or fatigue? And we can devise and design patient-centered outcomes for particular conditions. Patients with only osteoarthritis of the knee have different things that matter to them, maybe, than patients with pulmonary fibrosis or patients with heart failure, for example. And we can even tailor things further. If I want to know the difference between quality of life in patients with idiopathic pulmonary fibrosis compared to quality of life in patients with chronic hypersensitivity pneumonitis, for example. So it's really up to the investigator. What are you interested in knowing? What's the trial trying to show? What do we believe this intervention might impact? And that will drive the development of the patient-centered outcomes. So what do we, me and other people who are interested in patient-centered outcomes in pulmonary fibrosis, what do we think matter to our patients? And Ganesh hit on it, how you feel, how you function, and how you survive. Okay, that's great, so-called experts. But let's go to the real experts. What do patients tell us? And Ganesh's patient RN said it. I don't know if you caught it because it was a little bit fuzzy, but he wanted to be able to spend time with his wife. And I've interviewed a lot of pulmonary fibrosis patients, and I've done focus groups with a lot of patients and caregivers. And spending quality time with family is uniformly the most common response I get when I ask, what do you really want? And of course, they want to feel well physically and emotionally, right? We hear this all the time. I want to be able to do things without being short of breath. I want to get rid of this damn cough. I'm fed up of being so fatigued. I want to be able to go outside and not have to worry about how much oxygen I have and do I have enough to do the things that I love to do. I want to be able to bathe or shower without having to stop and rest and feel short of breath. And it's not just, I want to live longer, but how long can I live well despite having this condition? Those are the things that matter to patients. So if those are the things that matter, how do we actually go about collecting that type of information in the context of a clinical trial? Well, survival's pretty obvious. You got a binary outcome. Either we're alive or we're not. But living well, there's some nuance there, isn't it? We got to figure out how to capture what we mean by well and then weight that along with survival time. So a patient who lives a really long time with poor quality of life, is that better or worse than a patient who lives a shorter period of time with a great quality of life? It actually depends on the patient, doesn't it? We've typically measured how patients feel and function with questionnaires, and we've already bashed the 6-minute walk, and I'm going to pile on just a little bit and some slides coming up as well. But historically, that's what we've done, probably because they're the best things that we have or have had available at the time. And we know from questionnaire data that patients with pulmonary fibrosis have impairments in how they feel and how they function. These are quality of life data. Those of you who are patients out there have probably filled out this questionnaire called the SF-36. It's used all over the world in a bunch of different trials and conditions. And I want you to just focus on the red circles and the green circles. So we're looking at different aspects of physical and emotional health and physical functioning. And the red circles are scores from patients with pulmonary fibrosis, and the green circles are from age-matched folks in the general population. And you can see that in all of these different domains, all of these different aspects of health, patients with pulmonary fibrosis score worse, have greater impairments than age-matched people in the general population, with the exception of bodily pain. So if we're going to go about measuring these things, these abstract things in trials, what are some of the challenges? What are some challenges with measuring how a person feels? Well, it's very individualized, isn't it, from one patient to another. Even patients with the same condition vary incredibly in terms of how they feel, and certainly how they feel from day to day. You know, our textbooks used to just talk about, oh, patients with pulmonary fibrosis always feel terrible, and they're going to be worse and worse and worse and worse every time they come in to see us. And that, we know that's not true. But we also know there's a lot of ups and downs from day to day in how they feel. There's good days and bad days. And if we're going to ask the question, how does a disease impact how a patient feels? That's tough to get at, because a patient might have a very bad day because their knee hurts. You know, they just stumbled and broke their toe, or they have a cold, or they fell and broke their hip. That has nothing to do with pulmonary fibrosis, but it's going to impact how they feel. Any patient-centered outcome, whether we're looking at how you feel or how you function, we're trying to measure that, we have to do it scientifically, and there are 3 scientific benchmarks that all of these measures have to meet: validity, reliability, and sensitivity. And I won't get stuck in the weeds here, but we want to make sure that we're measuring what we think we're measuring. If I say I want to know about shortness of breath or cough, I want to make darn sure that the questionnaire that I'm asking my patient to fill out is actually talking about shortness of breath or cough, and in ways that are most meaningful, ways that resonate with the patients. We want to make sure that there's reliability, and that is, I don't want to score changing on my questionnaire if the construct really hasn't changed. If a patient is not more short of breath, I don't want my questionnaire suggesting they are more short of breath. In contrast, if things have changed, I want my questionnaire to be sensitive enough to capture that change. Okay, what's the challenge with measuring how we function? We've talked about the 6-minute walk test, and it seems so simple, right? Just walk for 6 minutes. but there's a whole lot of nuance and there's a whole lot of challenges. And some of those challenges are born out of the test itself. For example, should the course be round or should it be back and forth? Should you walk around the cone or should you walk to the cone? Should I tell the patient to walk as fast as they can for 6 minutes or as far as they can for 6 minutes? What the hell do I do with the oxygen? Should they carry it? Should they pull it? Should we have it on a concentrator in the middle of the course? Should the technician walk with the patient or not? Should we monitor saturation? What about heart rate? Should we ask about how short a breath the patient is? Maybe, yes, no, maybe, yes. Right? Creates a lot of variability. And most importantly, from the patient-centered aspect, what the hell does 1,200 feet on a 6-minute walk mean to my patient on a day-to-day basis? Can they shower without oxygen? Can they shower without having to stop? Does it take them an hour to get dressed in the morning? Translating those data into what it means for patients on a day-to-day life has been quite challenging. Okay, I'm done. I'm off the 6-minute walk, but I agree. All right. Let's talk a little bit about trial data. Ganesh showed you this. We're looking at a graph of lung capacity over time, and we know an antifibrotic medication slows disease progression as measured by FVC to the tune of 100 cc's difference from placebo on average, right? That's great. And it's really landmark finding. It's changed the whole landscape of this field. The problem is, when we've asked, what do antifibrotics do in terms of how patients feel and function? This is what we see, no difference. And one might look at that graph and say, well, you know, glass is half empty, antifibrotics have no effect. Or people who see the glass half full say, well, this is great. Patients are on these medicines for a year, the medicine's doing its work, and they're tolerating it just fine, and their quality of life is no worse. It's not what we all want, but it's a start. So it's true that antifibrotics may have no effect on patient-centered outcomes like symptoms and quality of life, but it may well be that the outcome measures we've used weren't valid, reliable, and sensitive enough to capture change. And those of you who have participated in a trial for patients with pulmonary fibrosis have undoubtedly filled out this questionnaire called the St. George's Respiratory Questionnaire. And I'm not going to bash on St. George's Respiratory Questionnaire. It has been the best thing that we've had, but I would argue it may not be good enough. And what's the problem? Well, the problem is that it was developed for patients with asthma and COPD, not for patients with IPF or pulmonary fibrosis. And because of that, many of the questions are off target. They don't resonate with patients with pulmonary fibrosis, and that off-targetness creates variability. It creates noise that may obscure the signal. In a trial, what do we want? We want a consistent approach to measurement, and we recognize that while we want all subjects answering the same questions about how they feel and function, every question that we ask may not resonate with every individual. And we're going to sacrifice that individualization for consistency. But as I alluded, we need to make sure that we're asking the right questions in the right ways so that those resonate with the patients under study and we get the information that we're looking for. So let's talk for a minute on how we might go about building a questionnaire or a survey. I'm going to take something abstract like quality of life, whatever that means, and I got to turn that into something concrete, something that we can measure. I got to put a number on it to figure out if our drug or our intervention moves the needle. And I'm glad Bray said this, and it's actually been mentioned in the first two talks. You patients out there, you are the experts. I'm not the expert. You guys have taught me everything I know about pulmonary fibrosis. And I think the rest of us would argue similarly. So if we're going to develop a questionnaire to find out how the disease impacts you and how your symptoms are and how you function in your daily lives, we damn well better go to you guys and have you tell us. So we start with patients, and we start with caregivers, and we ask those questions, either in focus groups or interviews, and we transcribe all of that information, and we do analyses, and we come up with a framework. We come up with a framework, and we actually use your words, hopefully, if we can, in the actual items that ultimately end up on the questionnaire. So I'll give you an example. Patients with pulmonary fibrosis will describe their cough in many ways, but nagging cough, a nagging cough, it just is nagging, I can never get rid of it. Well, nagging cough sounds like the right way to describe and ask about cough in patients with pulmonary fibrosis. So we do a bunch of statistics on it, we jumble the items, we get things packaged up, and then we pilot it, and then we actually do a whole bunch more analyses, and we get the end result. And our analyses are designed to figure out which items work and which items don't. And if we're interested in multiple dimensions like shortness of breath and cough and fatigue, we need to figure out how those dimensions, how the items are grouped in those dimensions, and how we score those individual dimensions. So let's talk a little bit more about the questionnaires that are available. The SGRQ has been used repeatedly in many trials of IPF. As I mentioned before, it was developed for patients with COPD and asthma. There are many items on there, and I would argue perhaps most items that sound good. And when I've asked patients, yeah, these kind of resonate, but there's definitely some that do not resonate with patients with pulmonary fibrosis, and they serve only to create noise and obscure signal. I'm not tooting my own horn, but I've done some work to develop a questionnaire specifically for patients with pulmonary fibrosis, and we're beginning to roll it out in different trials. It's called Living with Pulmonary Fibrosis, or LPF. And I started with focus groups and interviews. It has 2 modules, so it asks about symptoms that we believe and you have told me are the most important to patients with pulmonary fibrosis. And we ask about the impacts of those symptoms. So things that I think and that you've told me are relevant and meaningful and important. Shortness of breath, cough, energy, and the impact of those symptoms. There's a questionnaire called the King's Brief ILD questionnaire, again designed for patients with ILD, not necessarily pulmonary fibrosis, but we'll probably see that being used, and it has been used in some trials moving forward. I'm going to shift gears and put my clinician's hat back on. When we're taking care of patients, of course we want to remain patient-centered. How do we do that? Well, we have to have the time to talk to our patients, right? If my goal is to improve the things that matter to them, I need to find out what matters to them first. And hopefully we have the time and the skills to use what we call shared decision-making, where we're incorporating those patient values, what matters to them, their preferences and their judgments when we're faced with a crossroads, when we're trying to make difficult decisions. We don't want to put it all on the patients, and we don't want to grab the whole thing and make the decision for them. We want to share together, we want to partner and make the best decision for the patient at the time, recognizing that values, judgments, and preferences can certainly change. We want patients to feel empowered. How do patients feel empowered? They feel empowered when they have knowledge. We want to make sure our patients are educated about the disease, about potential therapies, about why we do what we do in clinic, why we measure the things that we measure. Many patients get power by gathering their own data, following their oxygen saturation, having the ability to titrate their own oxygen. Wearables, applications, this behavioromics kind of approach that we're going to see coming in the future. So moving forward, we definitely need questionnaires tailored to patients with pulmonary fibrosis, and those questionnaires need to be rigorously developed and they need to meet those 3 scientific criteria: reliability, validity, and sensitivity. We need a better measure of day-to-day physical functioning than the 6-minute walk test. And I think that will come, but we need to do a bit more work. And we need to find ways to incorporate these patient-centered measures in our clinical practice. So in summary, just to remind you, patient-centered outcomes focus solely and entirely on what matters to patients. And what we, the experts, and most importantly, you, the patients, have told us is that the things that matter to you are spending quality time with your families, how you feel physically and emotionally, and how you function in your daily lives. Historically, questionnaires have been the mainstay for gathering those data. To date, the data on quality of life and patient-centered outcomes for beneficial effects of antifibrotics are not great, but I think there's more to come on that. And we could argue that perhaps they work, the signal's just been obscured by the variability because we haven't asked the right questions. Thank you very much for your attention.